For decades, standard medical practice has categorized the menopausal transition primarily as a somatic event, a checklist of physical discomforts like hot flashes and night sweats. But examining the brain at a systemic level reveals a period of profound neuroendocrine flux and acute psychiatric vulnerability. When clinicians treat menopause solely through the lens of vasomotor symptoms, they often miss the underlying neurocognitive degradation. The physical symptoms are visible markers of a much deeper neurological shift. This chart tracks data from the Study of Women's Health Across the Nation, or SWAN, and the Penn Ovarian Aging cohorts. Looking at the timeline of a woman's reproductive life cycle, the data reveals a sharp 1.5 to 2-fold spike in the risk for major depressive disorder, or MDD, concentrating specifically in the late perimenopausal window. This specific data line isolates the de novo, or new-onset, MDD cohort. These are women with absolutely zero prior psychiatric history, yet their risk curve peaks steeply as they enter late perimenopause. As the timeline advances into the postmenopausal phase, the MDD risk curve stabilizes and drops off from its peak. The hormonal transition itself is the primary period of risk, rather than the final state of ovarian cessation. Effectively treating the menopausal patient requires a working understanding of neuroendocrine mechanisms, the compounding damage of sleep disruption, and the deployment of multimodal interventions. Recognizing menopause as a foundational neuroendocrine event provides the biological framework required to prevent midlife psychiatric morbidity. To understand why this vulnerability occurs, we have to look at the molecular mechanics of the endocrine system. As systemic reproductive hormones drop, the brain's emotional regulatory centers, specifically the hippocampus and prefrontal cortex, lose their primary biochemical support. Estrogen actively upregulates serotonin receptors in the prefrontal cortex and hippocampus, supporting mood stability. When estrogen drops during perimenopause, this antidepressant mechanism is removed. The resulting drop in serotonin activity leaves the neural network exposed and highly reactive. Estrogen withdrawal is only half the equation. Progesterone and its neuroactive metabolite allopregnenolone also plummet during this window. Allopregnenolone enhances the activity of GABA receptors, which provide the inhibitory signals that calm central nervous system activity. Without sufficient progesterone, the brain experiences severely decreased GABAergic tone. This sudden deficit in GABAergic inhibition explains the acute onset of anxiety, panic attacks, and physical restlessness reported by perimenopausal patients who have never previously experienced these conditions. This loss of neurotransmitter stability occurs as the brain's primary stress response system, the hypothalamic, pituitary adrenal, or HPA axis, is also being destabilized. Estrogen provides inhibitory feedback to the HPA axis. When estrogen is withdrawn, that inhibition disappears, leading to hyperactivation across the entire system. This hyperactivation triggers an exaggerated release of cortisol, pushing the patient into a state of chronic hyperarousal, where the nervous system overreacts to minor daily stressors. The simultaneous depletion of serotonin, the drop in GABAergic tone, and the unchecked hyperarousal of the HPA axis combine to form the biological architecture of menopausal affective disorders. The psychiatric distress of menopause is often driven by the domino hypothesis, a clinical framework outlining how physiological symptoms trigger a cascade of secondary psychological disruption. The cascade begins with hypothalamic dysregulation triggering severe vasomotor symptoms, or VMS. Affecting 75% of transitioning women, the intense heat of nocturnal hot flashes forces the body to wake, knocking over the next domino in the sequence, the destruction of healthy sleep architecture. Repeated nocturnal hot flashes pull the brain out of restorative deep sleep cycles multiple times a night, preventing critical biological processes like cellular repair and memory consolidation. Chronic sleep deprivation degrades the prefrontal cortex, stripping the brain of emotional regulation. This mechanical failure leads directly to the final stage of the cascade, full cognitive flux and major depressive disorder. Menopausal women routinely getting less than 7 hours of sleep per night face a 10-fold increase in their risk of developing clinical depression. Managing vasomotor symptoms functions as a primary psychiatric intervention by halting the mechanical driver of midlife depression. While these biological mechanisms are universal, the severity of the psychiatric outcome depends heavily on individual clinical risk variables. A prior history of major depressive disorder, postpartum depression, or bipolar disorder acts as a severe predisposing factor. The neuroendocrine shifts of menopause aggressively exploit these existing vulnerabilities. This chart compares the gradual hormonal decline of natural menopause against the sheer vertical drop caused by abrupt surgical menopause, such as a hysterectomy or oophorectomy. Surgical menopause forces the body into an immediate neuroendocrine shock. The sudden withdrawal of hormones occurs so rapidly that the HPA axis cannot adapt, maximizing the risk of acute psychiatric symptoms. Beyond internal biology, midlife is characterized by the clustering of concurrent psychosocial stressors. Environmental multipliers, such as caregiving burdens for aging parents, career transitions, and shifting family dynamics, compound the internal biological stress. Combining biological vulnerability with a patient's unique psychosocial load dictates that standard pharmacotherapy alone is rarely sufficient to stabilize their health. Pharmacotherapy, including hormone replacement therapy and SSRIs, addresses specific deficits, but it only solves part of the clinical picture. This necessitates non-pharmacological therapies, starting with cognitive behavioral therapy, specifically tailored for menopause, or CBT-MENO. CBT-MENO interrupts the psychological domino effect by reframing negative cognitive appraisals of somatic symptoms. This reduces the reactive anxiety that follows a hot flash, breaking the behavioral feedback loop. Alongside cognitive reframing, mindfulness-based stress reduction, or MBSR, plays a specific role in regulating the autonomic nervous system. MBSR training measurably increases parasympathetic nervous system activity. This reduces amygdala reactivity and mitigates the HPA axis hyperarousal caused by estrogen depletion, lowering the patient's baseline stress level. Aerobic and mind-body exercise also serves as a vital neurochemical countermeasure for menopausal affective disorders. Consistent aerobic exercise stimulates the release of brain-derived neurotrophic factor, or BDNF. BDNF is a protein that enhances neuroplasticity and increases hippocampal volume, naturally upregulating the serotonin systems degraded by estrogen loss. These non-pharmacological interventions enact measurable structural and chemical repairs in the human brain. Translating these mechanisms into patient outcomes requires a specific clinical workflow, starting at the primary point of contact in midlife healthcare. By default, the gynecologist acts as the clinical gatekeeper to menopausal mental health. However, relying solely on patient self-reporting during a routine exam is a systemic clinical failure. Many patients will not independently volunteer psychiatric symptoms in a gynecological setting. Clinicians must systematically integrate validated psychiatric screening tools directly into the standard perimenopausal exam workflow. The Patient Health Questionnaire 9 for depression and the Generalized Anxiety Disorder 7 scale for anxiety should serve as the required baseline metrics to objectively measure symptom severity and guide the intervention strategy. Clinicians should automatically trigger these psychiatric screenings for any patient reporting severe vasomotor symptoms or chronic insomnia, given that the domino hypothesis is already in motion. From there, the clinician can deploy a unified treatment model, blending treatments like hormone therapy with targeted lifestyle interventions and cognitive therapy, based strictly on screening scores. Proactive, neurobiologically informed screening transforms the menopausal transition from a period of acute psychiatric vulnerability into a managed, resilient stage of women's health.